Hello and good evening, everyone. Welcome to our 29th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Adam Getachew. I'm the co-founder and CTO at Prevalence Ethiopia. And it's a pleasure to have Dr. Deka Semire with us to give us the presentation on the suicide prevalence and associated factors. Dr. Deka is an assistant professor of psychiatry and currently working at Jijjiga University, Sheikh Hassan Yabari Referral Hospital.
Okay, thank you, Adam. As Adam introduced, my name is Dr. Deka Semire, and I am a psychiatrist. I am currently working at Jijjiga University, Sheikh Hassan Yabari Referral Hospital. So for today, I will be talking about suicide prevalence and associated factors. So I chose to talk about suicide because it's a very relevant public health issue. And also, it is one of the psychiatric emergencies that we deal with, and it is a preventable problem. So that's why I chose to talk about suicide. So like Adam said, I will give you the presentation, and while I'm presenting, you can forward your questions on the chat box. And when I finish presenting, I will reflect on your questions. So welcome again to the presentation. And I will start. So this is my content. I'll give you introduction. Then I'll talk about epidemiology of suicide. Then I'll talk about etiological factors for suicide, then risk factors and protective factors for suicide. And I'll talk about common methods people use to take their lives. Then I will talk about warning signs people give out when they think about attempting suicide. Then I'll talk about how we assess these patients and I'll talk about prevention and common challenges. Then I'll talk about how we manage people who present to us with suicidal thoughts. Finally, I will tell you common myths and misconceptions about suicide. So suicide is a self-inflicted death with the evidence that the person wanted to die, they intended to die. It is not an accident. It's not something that has happened out of their will. It is something they have planned and wanted to do. So before the person commits suicide, there is suicidal ideation. So suicidal ideation can be active or passive. So the active one is actively thinking about serving as an agent of one's own death. And the passive one is when the individual wishes to die, but hasn't taken further thoughts towards how they want to take their lives, or haven't put out plans on how to do it. So these people might come to you and say, I wish I went to sleep and never woke up. Or they might say, while crossing the road, I thought about being hit by a truck and die there. So this is a wish, but it is not active. But this shouldn't be dismissed, because the person is thinking about taking their own life, thinking about their own days, but not in an active way. But through time, this might turn into active suicidal thoughts. So it should be addressed when someone mentions this. So suicidal attempt is self-injurious behavior with non-fatal outcome. The person has tried to take their life, but they didn't complete it. Maybe they were found by someone else, or the method they used failed. So that is called suicidal attempt. So suicide is never a decision taken in a spur of a moment. whenever someone commits suicide, this person has been thinking about this for a very long time, probably. They have been trying to balance the pain they are feeling and the will to live. So when that balance shifts towards the severe pain and hopelessness and helplessness they feel, that's when they commit suicide. But they have been contemplating it for a very long time, and it is not something that happens suddenly. So epidemiologically, suicide is a worldwide problem. It's a global problem. It happens everywhere throughout people's lifespan. It's not something that happens in certain regions of the world and doesn't happen in the other regions of the world. So it's said that over 700,000 people die by suicide annually, and 20 million people attempt suicide. Thankfully, the gap between people who attempt suicide and people who actually commit or complete suicide is very high. But still, a lot of people die of suicide annually throughout the world. And there is increased suicide rates in people who live in low and middle income countries. So globally, suicide accounts for 52% of all violent cases in men and 71% of all violent cases in women. And this number is different because men tend to die from other violent causes of this. That's why the number is a bit lower, but it is when compared to women. So every 40 seconds, someone commits suicide. This is how much a big issue suicide is, not even 1 minute. So someone dies somewhere every 40 seconds. So that's why suicide should be talked about more often, because through our awareness creation and through treatment, it can be prevented. And whenever someone commits suicide somewhere, a lot of people attempt suicide in other places. So in our country, there is no, much data regarding the number of people who die of suicide. There is data lacking. Actually, throughout the world, the data, the quality of data is very poor. And it said that the number of people who commit suicide annually is higher than 700,000. And this is due to poor reporting. Suicides don't, on the day's registration form, suicide is not registered properly. Also, suicide is illegal in many countries. Even our neighboring country, Kenya, in Nigeria, in countries like India, Bangladesh, Pakistan, in many countries, suicide is illegal. So even if someone attempts suicide, it will go unreported because no one wants to get punished for their attempt of suicide. So the number is said to be lower, and I think the same applies to our country because there is poor quality of data. But it said that from 2005 to 2015, the number of people who attempted or completed suicide increased from 7.9 to 8.4 per 100,000 population. So etiologically, it said that people who have a family history of suicide have increased risk of suicide risk, which is up to 30 to 50%. And in our psychiatry practice, it is one of the family histories that we take. We ask individuals if there is a relative who has attempted suicide or who has died by suicide, and it is included in our routine evaluation. So it said that if coming to the biological factor, it said that the stress response in people who are suicidal is dysregulated, and also serotonin and its metabolites are decreased in the brainstem and frontal cortex. And these biological factors are similar to that is seen in the people who have major depressive disorder. So whenever there is a major depressive disorder, suicide should be assessed for, because biologically they have the same type of pathologies. When we come to psychological factors, Sigmund Freud said suicide represents aggression turned inward against an introverted, ambivalently catcheted love object. Simply put, this means you feel both love and hate towards someone. but probably you both hate and love your father because of the bad things he has done to you throughout your childhood or throughout your teenager life. You feel hate towards your father, but he is your father and you also love him. So that love and hate you feel towards that person, he is your father figure, you can't hate him, so you will internalize that hate you feel towards that person. Then now you hate yourself. So you will be aggressive towards yourself and you will take your own life. That's how Freud explained it. And Menninger said that suicide is an inverted homicide. So the patient, homicide is when you're feeling anger towards someone else, right? But suicide is when you are feeling aggressions towards your own self. So he said it is an inverted homicide. Coming to sociological factors, there is Durkheim. There's Durkheim's theory. So Durkheim is an individual. He's a sociologist who lived between 19th and the 20th century, and he wrote a lot about suicide. And he said people commit suicide because of their different relationships in their society. And he said there are egoistic people who are not integrated in their society, who don't have a strong relationship with the society. They are alone. There is loneliness. They are most likely unmarried, and these people usually commit suicide due to this poor relationship with their society or poor integration. And the other ones are altruistic people, and he said these people are very much integrated in their society. So this integration in their society is their cause for putting their life at risk or for committing suicide. And these people are people like soldiers, fire workers, police. These people, they tend to put their life in line because they are very much integrated in the society and they care about the society. The other ones are anomic ones. These have dysregulated, disturbed relationship with their society, and due to that disturbance relationship with the society, they feel isolated, hopeless, or they might feel helpless, and that's their reason to committing suicide. So risk factors for suicide. Age is one of the risk factors. Suicide is rare before puberty, and between the ages of 35 and 64, it is the fourth leading cause of death. And between the ages of 15 and 24, it is the third leading cause of death. For people older than 65 years, the rate is lower, but once they attempt, they complete the suicide. They won't be found. They won't survive. They will die. If they attempt, they die. So the suicide completion rate is high for people who are older than 65 years of age. The other is sex. So there is a difference between men and women regarding suicide attempts and death by suicide. So women tend to attempt suicide more, and men tend to complete suicide more. So the attempt is higher in women and the suicide completion is higher in men. And the reasons for this are, men usually have increased rate of substance abuse like alcohol or other drugs, and also their access to lethal means. They have access to, guns or other firearms than women, and usually women tend to commit suicide by poisoning, where they get found by a family member or someone else and they get saved. The other is previous suicidal behavior. This is the single most important predicting factor for someone to complete suicide or to attempt again. And if someone attempted before, next time they attempted, they are going to complete it. So if someone, while you're evaluating, if someone says, I have attempted suicide before, that should create an alarm, and you should assess if they are currently suicidal. The other is being unmarried, divorced, or widowed because of decreased responsibility and because of lack of someone to rely on, that you have good relationship with and that can help you, give you hope, these people are said to have increased risk for suicide. The other is occupations that are very much stressful and cause psychological stress are said to be a risk factor for suicide. And one of these occupations is physician, being a physician, and physician suicide is very much common. And in the United States, around 300 physicians take their life annually. So this is a very high number, right? And the number of suicide completion between men and women is the same because their access towards lethal means like drug overdose is the same, so their completion rate is equal. Like the general population. In the general population, I said attempt is higher in women and completion is higher in men, right? But here the completion is equal. They attempt, they die marathon. And also there has been a research that has been done by one of my colleagues recently, and she tried to assess physician suicidal ideations, and what she found is almost similar with the rest of the world. There is increased suicidal ideation in physicians, and the reason she found is that the physicians who said that they have suicidal ideations also have depressive symptoms. Also, they work in very much stressful environments, and also poor economic status to support themselves and their families. And these are the reasons given by the physicians. So generally, it's said that starting from med school, physicians get harassed by their teachers, nurse, any hospital staff tends to harass medical students. And also, the expectation is very much high from family and other members, and even the person himself or herself. And also the exams and the different, stresses while they are in middle school puts them at risk for depression. And due to the busy schedules, usually they don't tend to get treated or assessed for this depression. And this later on causes their suicidal attempts or their deaths by suicide. The other is stigma. Stigma is very much high when it comes to suicide, or you can't say I have these feelings to your colleague or someone else because you feel like they might, judge you. So that's also another reason for them to continue having these depressive symptoms or suicidal attempts without seeking help. So the other risk factor for suicide is economic condition. Like I said, suicide is increased in low and middle income countries. So poor economic status is one of the risks for suicide because it leads to stressful life situation. Substance use, I already talked about. The other is childhood trauma. So this usually leads to behavioral deviations that might later on lead to depression or other personality disorders, and that might lead them to attempting or committing suicide. The other is physical illness. People with severe physical disabilities, people with end-stage cancer who feel hopeless and helpless tend to commit suicide. Medications also can be risk factors for attempting suicide. Medications like anti-epileptic medications like gabapentin might be risk factors for someone to have impulsive behaviors and commit or attempt suicide. Antipains like tramadol are also said to increase impulsivity and suicidal behaviors, and antidepressant medications like selective serotonin receptor inhibitors are said to increase impulsivity and suicidal behaviors. So in our OPDs, when we treat major depressive disorder and when we order SSRIs, selective serotonin receptor inhibitors, we psychoeducate the patient on the possibility of being impulsive and increased suicidal ideation, and we add benzodiazepines like clonazepam for them to feel calmer. So the other risk factor for suicide is mental illness. Suicide and mental illness have very much strong relationship, and the risk increases up to 12 times in people who have mental illness. And the commonest mental illness that causes suicide is mood disorder, specifically major depressive disorder. For people who have major depressive disorder, the risk of suicide increases up to 20 times. So that is very much high, right? So depression is one of the mental illnesses that usually go hand in hand with suicide. The other is schizophrenia. For people who have schizophrenia, usually they attempt suicide due to command hallucinations that tell them, go kill yourself, go do this and that. They might, follow the command and attempt suicide. Also, people with schizophrenia, especially at young age, they commit suicide when they get discharged, and that is due to their insight. They because now they're feeling better, they tend to recognize what's going on, what they're going to miss out because of this chronic illness that they have, and they tend to commit suicide because they choose not to live like that. So that is one of the common causes of suicide in people with schizophrenia. And also in people with mood disorder, something I didn't mention, for people with major depressive disorder, they also tend to commit suicide when they get better after treatment. They tend to commit suicide because now they have the energy. One of the symptoms of major depressive disorder is lack of energy. But now that they are being treated and getting a little better, they tend to attempt suicide. The other is anxiety disorders. Because of the dread and apprehension they usually feel, they just want to turn off the pain and they might commit suicide. Substance use disorders, alcohol and other drugs are the reasons for people to have impulsive type of suicidal attempt. And substance use disorders are usually comorbid conditions in most of the mental illnesses. Mood disorders, schizophrenia, anxiety, any mental illness, usually substance use disorder is a comorbid disorder. The other is personality disorder. Personality disorders in the cluster B, the histrionic and borderline personality disorders, tend to have increased risk of suicide, and this is because of their impulsive type of behaviors and poor anger control behaviors. So borderline personality disorder patients, they have parasuicidal behaviors, where they cut themselves, they burn their skin and do things like this in areas where people can't see. They do these things, and they do this because they feel a strong void, and they feel they are very much disconnected, and they say, whenever I cut myself, I feel alive. I know that I am living. Whenever I feel the pain, I know that I am living. That's one of the reasons they do it. But sometimes, due to this impulsivity they have, they might attempt suicide. So protective factors. The most important protective factor for people who are suicidal is the ability to seek advice and seek treatment. Because, like I said earlier, suicide is preventable. It can be prevented if the person gets in time treatment and they have appropriate follow-up. It is preventable. So the ability to seek treatment is one of the most important protective factors. The person having cognitive flexibility is one of the important protective factors, because people attempt suicide when they are in severe life stresses, right? So if they have cognitive flexibility, they might be like, this is temporary, I will get past this. So they will refrain from attempting suicide, as suicide is a permanent solution for temporary problems. The other is coping strategies. People who have good problem solving skills tend to, say, I can get past this, or tend to solve their problems in a healthy way. So that is also another protective factor. The other is having a healthy lifestyle. Like I said earlier, people who use substances are at risk. So healthy lifestyle is one of the protective factors. Active social networks, being confident in the sense of personal values are also protective factors. Being religious or spiritual, because suicide is it is a sin. A patient might come to you, they will tell you, I wish to die, I want to die, I want to take my life. And when you ask them, why haven't you done it so far? They will tell you, I will go to hell if I do it. So religion is one of the protective factors for people not to commit suicide. The other is parental responsibilities. I said earlier in the risk factors, people who are unmarried or widowed or divorced tend to be at risk for suicide, because especially the unmarried ones, they don't have parental responsibility. So someone might want to commit suicide, but they will tell you, I can't leave my child. I don't want to leave my child alone in this world. So that's why I'm staying. So parental responsibilities, one of the protective factors. The other is family connectedness and strong social support. You lose something, you get fired, someone in your family dies, you are in a very much stressful life situation, but because of the help that you get from your family, your friends, or people around you, you will try to get past that. So it is a protective factor. So coming to methods people use to commit suicide, hanging is the commonest method globally, but in the United States, firearms are the commonest methods people use to commit suicide. The other is poisoning. So people use pesticides and other medications to commit suicide, and also jumping from buildings or bridges are other methods of committing suicide. There is a difference between the methods used by men and women. So like I said earlier, men tend to use firearms and women tend to poison themselves to commit suicide. So like I said on the first slide, suicide is not something that happens on the spur of the moment. I said the person has been trying to kill themselves. The person has been contemplating this. The person has been giving signs here and there to be heard, to be saved, but they got unheard and they committed suicide. So I'm sure you all have someone that has committed suicide, whether it is a family member, a friend, or someone or you myself have suicidal thoughts. So whenever someone gives you these warning signs, please don't dismiss them. Whether you are a physician who's working at your respective OPDs, if a person gives you one of these signs, you should explore more. And if it's beyond your scope, you should refer this patient to a psychiatrist. If a family member or a friend says these things to you, you shouldn't dismiss them. You should say, okay, this is serious. We should talk about this, or you should seek help from this person, or you should, do this and this. You shouldn't say, it is sin. ሰዎችን discourage ያደርጓቸዋል, judge ያደርጓቸዋል. So saying that, we want to stop that thought of being suicidal. So later on, you will hear that person has died. So people who have suicidal thoughts, they talk about them openly. They say, I'm going to kill myself openly, but people might take it as a joke. because you won't expect someone to say, I'm going to kill myself, or people might say, he's doing this to get attention and might dismiss it. But it might not be just to get attention, they are actually telling what they are going to do. The other is people might say, I wish I was dead. I wish I hadn't been born, So whenever you hear this, you should explore more. You should say, why did you say that? How have you been feeling lately? The other is if someone has a means to take their own life, that is another warning sign, if they have bought a gun, if they have been stockpiling pills, there is a risk there, that is another warning sign. So these people might withdraw themselves, because like I said, major depressive disorder is one of the risks for people to attempt suicide. So social withdrawal is one of the symptoms for major depressive disorder. So these people might withdraw themselves and want to be left alone. They might have mood swings, and this is common in people who have borderline personality disorder. The other is being preoccupied with death, dying, or violence. And these people might tell you, I feel trapped. There is no hope. There is, the future is not bright. So this is another warning sign. They might increase their substance use behavior. They might change their normal routine, which might be one of the symptoms of major depressive disorder, changing their eating or sleeping patterns. They might do risky things, like self-destructive things like using drugs excessively or driving recklessly, or having multiple sexual partners where they have unprotected sexual encounters. They might give away their belongings, to someone else. Like they might write a will, and they might give their other belongings to someone else. Like, I don't need this anymore because I will be gone soon. So they will give out the things they have. And they might go say goodbye to long-time friends, family members, like they are not going to see them again. And also they might be very much anxious, agitated, because it is very serious, right? The thought of going to die is very much scary. They do it because the pain they are feeling is unbearable, not because they feel comfortable doing it. So even yourself, if you think about your days, or if you think about taking your own life, it's very much scary. Even hearing about someone who has done it is scary, and so that's why they feel anxious. This is a summary of the warning signs I have already talked about. So the most important thing is prevention when it comes to suicide. Actually, when it comes to any illness, prevention is the key, right? But suicide, since it is very much sensitive, prevention is very much important. So WHO planned to decrease suicide rate by 1/3 by 2030, and there is an action that has been done towards this suicide, and there is a logo that is the acronym is LIFE, and it is limit access to means of suicide like pesticides, firearms, certain medications, interact with the media for responsible reporting, because the media plays a very important role. It has both positive and negative roles regarding preventing or causing suicide. And the reporting should be very much careful. The positive input of the media is that they might, give the information for people about the awareness of suicide, health-seeking behavior. They might, post hotlines that can be, called whenever someone feels suicidal. So that is positive. That is working towards preventing suicide. But reporting very much detailed information about how someone committed suicide, like it is a fantasy. might cause for someone who has suicidal ideation to go in to commit suicide, as that person has did it, the person that has been reported on the media. So it is very much important to be careful when reporting these suicides for the media. The other is fostering socio-emotional life skills in adolescents, because like I said, cognitive flexibility and coping strategies are one of the most important protective factors for people not to commit suicide. So developing those skills is important. And then early identification, once it is identified, proper assessment, and then management and follow-up for people who have suicidal behaviors. So this is very important. So what are the challenges? Stigma is the biggest challenge. Even for people who are said to be advanced in their educational levels, who have degrees and other things, they say suicide እንዴት አይነት ነገር ነው ያላቸው attitude, and it is a taboo አይደለም? Especially in countries like our country, where most people have certain type of religious affiliation. Talking about suicide is like, that person is going to hell, this person is a sinner, he is like this and like that. It is a taboo to begin with. And since it is a stigmatized issue, people won't go for treatment seeking, and there's no treatment seeking, they are going to commit suicide. So these things are the biggest challenge. The other is data quality. Like I said, in the epidemiology, the report on people who have committed suicide and attempted suicide is usually not included in hospital registration forms. So in our country, it is planned for 2025 to include suicide, days by suicide, in the days registration form. And also having suicide prevention, lack of having suicide prevention policies in most countries is one of the challenges for for not preventing suicide as it should be prevented. So these are summaries for strategies to prevent suicide. I think I've already talked about this. So we couldn't prevent it. Now the person is suicidal, so we should assess properly. So we should have a clear and complete evaluation and clinical interview. So we have to ask them about their suicidal thoughts, because suicidal ideation is linked to completed suicide. So we have to have a clear history, starting from day's wish. Do you have a day's wish? If they say yes, then you will go asking about active suicidal thoughts. Do you think about taking your own life? Do you think about hurting yourself? And you should always try not to be judgmental, because they came to you. It's very difficult to come to a health facility and seek help for this, because it's a very stigmatized issue, like I said. So you should be very much careful with your tone. You should make sure that you are not presenting yourself as a judgmental person, and you should try to show your concern for the patient. So do you feel like hurting yourself? Do you want to hurt yourself? And if the answer is positive, you should ask them if they have a plan, because the clearer the plan is, there is high completion of suicide. So do you plan to take how do you plan to take your life? So you should have a clear picture of how they are going to do it. They might say, I want to hang myself. Okay, so have you bought a rope? Do you have a rope? So they might say, yes, I have a rope, or yes, I'm going to purchase the rope. I have already prepared the money. I have the money for it. So I'm going to go to one of the neighborhood shops, and I'm going to buy a rope. Then you have to ask, where are you going to do it? So if they tell you, I'm going to hide from my family members or I'm going to hide from my spouse, I'm going to do it when there is no one available. So they don't want to be saved. They don't want to be saved. They don't want to be found. So they have a very strong intent to kill themselves ማለት ነው። ከዛ በኋላ you should say, but why do you want to kill yourself? Why do you want to do it? They might tell you, the world will be better off without me. I'm a burden to my family. I'm a burden to my spouse. There is no hope for me. Or that person, their spouse might have died, and they might say, when I die, I'm going to unite with my spouse. They might do it for that. So you should ask them their purpose, why they want to do it, and later on you reflect back on these things ማለት ነው. Then you should always ask for the potential for homicide, because it's aggression. Suicide is being aggressive towards oneself, but these people might also be aggressive towards other people. So you should ask if they are also homicidal. So once you assess these things, if there is a strong risk that this person is, actually when someone is suicidal, you feel it, you know it. So the clinician's judgment is one of the most important factors to say this person is actually going to do it. So everything is positive. The person has a strong suicidal ideation. They have a clear plan. You try to tell them, the world won't be better off without you. You're not a burden. Things will be okay, and things like that. But they still want to go. They still want to, shut down the pain. Then you will go to management. So this person, the first thing is safety. You have to make sure that the person is not going to do it under your watch. So, or if you say, okay, you have these things and go home, they might do it. So this person should be admitted. They should be admitted, and when you admit them, you have to involve family members, or you have to involve friends, because you can't attend to the patient by yourself. So you admit them, and you have to make sure there are no ropes or other things that they might try to take their life with while they are still in the hospital. So they should be guarded 24/7. You have to make sure they are safe. You have to make sure that they are not going to do it right there. So after you make sure that they are safe and they are not going to do it, then what you are going to do is you will assess for the underlying cause for their suicide. Mostly there is some sort of mental illness. So you will address that mental illness. You will treat that mental illness. In some cases, the patient might tell you, I have suicidal thoughts. And when you say, why haven't you tried to attempt it until now? They might say, I have a child, like I said earlier, and I can't leave them. I have this and that upcoming responsibility. I can't do it now, and things like that. You have to give them your phone number and tell them to call you whenever they feel suicidal, because there are no hotlines in our country where people can call and communicate their feelings. There are no such things available in our country. So you will give them your personal phone number, and you will tell them to call you anytime. Call me anytime you feel suicidal. So after you've done this, for patients who have major depressive disorder, usually the treatment, usually we use tricyclic antidepressants like amitriptyline to treat depression. But here you have to balance the risk and the benefit, because overdose with TCAs is very much dangerous. So you have to balance the risk and benefit. And if you decide to give them, you have to give them medications for only a few days so that they won't overdose with the TCA. So you will give them medications for a few days. You will have short appointments, and you will try to solve the problem with frequent meetings. So this is for people who have already completed suicide. You have a patient who have completed suicide. So that person has friends, families, I don't know. There are people who know that person. So you have to address their feelings. They might feel guilt, they might feel anger. So that should be addressed. Those patients should be, talked with, because I have wrote it in my last slide. Suicide, it doesn't take away the pain. It gives the pain to it is giving the pain to your loved ones. You commit suicide, your spouse, your mom, your sister, your brother, everyone who loved you will take that pain. They will feel guilt. They will feel that pain. ይህም ባረግ ኖሮ እንዲህ ብላት ኖሮ እንዲህ ባረላት ኖሮ እንዲህ ቢሆን ኖሮ ቢሆን ኖሮ እያሉ በጣም ከራሳቸው ጋር ስትራግል ያደርጋሉ። So later on, this might lead to depression and for themselves to commit suicide ማለት ነው። So their feelings should be addressed always. You should try to address the feelings of the family members and friends, and also yourself. It's very difficult to lose a patient, and that might be seen by yourself as a failure. So you should talk to a senior physician who can help you ማለት ነው። So common myths and misconceptions regarding suicide. So talking about suicide increases the chance of a person will act on it. So this is actually false. Talking about suicide reduces suicidal ideation, because the person talks about suicide. Now that is a warning sign for you. So you will help them, you will treat them. If it is a family member and if you can't treat them, you will tell them to go seek treatment. So talking about it doesn't give them idea. You're not going to put ideas in their mind. It is something that they have been thinking about already. So you're not going to be their cause. Talking about it is not a risk. It is very important for them to talk about it, so that will give you a hint, and they might be saved. The other myth is people who talk about suicide are just seeking attention. Actually, people who talk about suicide are people who are going to commit suicide. So it is a warning sign. They are not saying it for an attention. They are saying it because they are going to do it. The other myth is suicide can't be prevented. It can be prevented, but the problem is it is unpredictable. So these people usually they feel hopeless, helpless. They have intense emotional pain and negative view about themselves, the world, and the future. So if they seek help, they can be treated, and so that suicide can be prevented. The other is people who take their own lives are selfish, cowards, or weak. And this is also, false. The fact is that it is not a choice. Nobody wants to take their own life. They do it because they are in a very much unbearable pain. They can't take the pain anymore. They can't move forward anymore. That's why they do it. They are not doing it to hurt anyone else. Actually, they are hurting themselves by attempting suicide or by taking their own life. The other myth is barriers to bridge safe firearm storage and other actions to reduce access to lethal methods of suicide don't work. This is also false. The fact is limiting access is one of the preventive mechanisms for people not to commit suicide. And usually, you might think this person wanted to commit suicide by a firearm. But even if we take away the firearm, they might use other thing. But that's not true. If you take one lethal means from them, there is a high chance of them being treated and not actually thinking about attempting suicide some other time. The other is suicides always occur without warning. And the fact is, I already told you, there are warning signs before someone attempts suicide. And treatment doesn't work is the seventh myth, and this is also false. Suicide is preventable. The underlying causes are mostly treatable, and people can be saved. So suicide doesn't end the pain, it just passes it to someone else. So this is the last slide. Thank you everyone for your attention. Now I can go to answering your questions.
Yeah, thank you so much, Doctor. Yeah, let's proceed to the question and answer.
Okay. And so I see here 6 questions. The first one is, which mood, the manic or depression, is a greater risk factor? So the greater risk factor is actually major depressive disorder. The risk is 20 times increased with major depressive disorder, but people who have mania also tend to commit suicide. And that is due to their impulsivity and reckless behaviors. People who are manic in their active manic state, one of the criteria for mania is recklessness, or reckless behaviors. So that recklessness might lead to them into taking their life, and also they might be disorganized and take their lives. But this is more common for people who have depression. The other question is, what is your justification for recent suicide process out in our country and all over the world? You know, those who posted sad news in Facebook, is there any connection between certain season and suicide? What is the effect of social media for suicide? So thank you for raising a very interesting question. I think I have already talked about this, how the media, you know, when I say the media, the internet is also included. So the media plays a very important role in suicide. The things you see on the internet might be the reasons for someone to commit suicide. So the recent increase in Greek, I can't say it has increased because there is no proper research that has been done on it. But one of the reasons for people to commit suicide is economic instability, poor economic status. And as we can see, there has been fluctuations economically, and there have been wars here and there, and that might, you know, cause hopelessness. You know, what's there to live for? You know, why should I keep living? So people who were already at risk, who had depressive symptoms, might be like, you know, I think the world is the future is not bright. The world is not, you know, a good place for me to live in. They might commit suicide. So that might be one of the reasons. And as you said, season, is there a common season? You know, sometimes there is a suicide type that is called suicide contagion. You know, when someone, a public figure, or, you know, someone who's very much famous, commits suicide, and this is reported on the media in a very much unresponsible way, like you know, in a fantasized way, people who have been having suicidal thoughts might commit or attempt suicide. So suicidal contagion is one type of suicide. I think I have answered the question. What is the role of social media? I already answered this. Suicide in religion, what is the role? As I said in the presentation, people who have strong religious affiliations are protected from committing suicide, because suicide is a sin in any religion. Taking your own life is a sin. So people won't do it, they won't do it because they fear God. They don't want to go to hell. They don't want to seen. So it is a protective factor. The other question is, a patient with postpartum depression told me that she started to understand the people that commit suicide, they do it because everything seems suffocating. And she told me that she is scared because she understands them that one day she might want to take her own life as well. So can this case be considered as a suicide ideation or thought? Yes. She's talking about this. She's talking about suicide. She's talking about how some other people have done it and how they have probably, she's probably underlying way saying they got relieved from whatever stressful life event they are going through. So I think if I do it, I might also be relieved. So I think you should advise this person to seek help, because already she's depressed, she should seek help. And in addition of being depressed, she has suicidal thoughts. So she should get help. Okay, Abinat Mamu said, is it allowed to interview family and friends regarding someone's suicidality? I don't understand. Are you saying their own suicidality? If that is the case, you can ask them in a non-formal way. You can ask them if they think about hurting themselves, and if the answer is positive, you can connect them with someone who can help, mainly a psychiatrist. Okay, so anonymous attendee again asked 3 questions. So this person said, is there any chance in which a person can have a sudden suicidal ideation and commit suicide? Usually, people who commit suicide don't do it suddenly. They think about it for a very long time, and they do it when there are no ways out. But sometimes people do it suddenly, especially people who are under the influence of alcohol. That's why substances are very much risky. So under the influence of alcohol, the person was already depressed and has suicidal thoughts, and now they're under the influence of alcohol, they might commit suicide. So the other is people with personality disorders. Usually people with personality disorders do things like cutting themselves and crying for attention. And it might get out of hand and they might end up taking their own life. So these are the cases where people do it impulsively, but mostly people think about it for a very long time and they do it later on. What can one do if they have suicidal ideation? Seek help, seek treatment, get evaluated, and get treated. That's what you have to do. And like I said earlier, it's one of the myths to say suicide, but the person who commits suicide is selfish. They do it because the pain they feel is unbearable. The other is how can an individual treat himself after his family member passed away due to suicide? And they're feeling regret. So usually we address the person where a family member or friend has died. They should be evaluated, they should be managed. And if you have a family member who has committed suicide and you repeatedly think about about them, you obviously will think repeatedly about them. But if you feel this anger, this guilt towards this individual, and you have you feel hopeless, excessive sadness and things like that, I think you should seek help. Is antipsychotic medication prevent suicide? The thing is, you have to treat the underlying problem, whether it is psychotic disorder, mood disorder, any kind of mental illness. So the underlying problem should be addressed, and that will prevent suicide ማለት ነው። Is there any medical legal issue related to suicide? Yes, there is medical legal issue related to suicide because proper documentation is the most important part. When you assess the patient, you should, thank you for raising this question. When you are assessing the patient, you should have a proper documentation of the things you talked about, the things you said, what they said, what you said. That should be properly documented. Because sometimes, even if you try to prevent it, even if you do everything you can, the person might go and commit suicide. So in that case, the family might sue you and say, you know, they had follow-up with you, you have been treating them, how come they commit suicide? In that case, your proper documentation will defend you. Can chronic illness be a risk factor? Yes. People with chronic illness, end-stage cancer, or end-stage renal disease, or any other severe physical illness, people with disability might be at risk for suicide, because these things usually cause depression and lead to suicide. Why isn't available in our country that physician-based days, like when they are sick and not treatable like the other countries? Or is it available? Can you please, Dagi M, can you please write your question again? What medications and psychotherapy are effective towards suicide? Medications based on the illness. If it's a mood disorder, mood stabilizers. You know, if it's bipolar, if it's depression, antidepressants. If it is psychosis, antipsychotic medications. If it is anxiety, also we use antidepressant medications. So based on the illness, you prescribe the medications. And coming to the psychotherapy, therapies like cognitive behavioral therapy, which help with coping skills and cognitive flexibility, and good problem solving skills are very helpful for patients who are suicidal. Okay. How can we prevent it? I already talked about this. Religious aspect, I already answered. Is there direct relationship between suicide and homicide? Occasionally we see people who have conducted homicide and then committed suicide. Yes, there is a relationship, and whenever you assess suicide, you should also ask about homicide. My friend always mentioned about suicide almost 5 years, and he have risk factors that you mentioned, even though he visits psychiatric clinic every 2 weeks, and there is any additional thing which I can do. You just have to give your ears to him, you know. You should listen. Don't be judgmental in a non-judgmental way. Try to tell them that you understand their pain, that you understand what they are going through, and try to tell them that everything will be okay. Otherwise, I think the physician who is treating them can handle the treatment part. Is there epidemiologic data in our country about how many physicians took their lives? I haven't found this. There is, I don't think there is any data. Can chat chewing cause suicide? It doesn't cause directly suicide. You won't die out of suicide of chewing chat, but substance use in general as a comorbidity for people who have other mental illnesses increase the risk of suicidal attempts. When do we discharge a patient? When their underlying problem is treated, when they get better, when they show you signs of hope, when they reassure you that they won't, they're not thinking about it anymore, and they're better now, they're okay now, and if they have these thoughts, they will contact you, they will communicate you, they will come back to the hospital. If you are, you will know, you know, if you are treating the patient, you will know. So if they give you these reassurances, and if you are, you know, sure that they will abide by what they say, they can be discharged. Can we study suicide prevalence and socioeconomic determinants in our setup? Yes, please, if you have a plan, do it. If you have a plan of studying this, do it, because data is lacking. There is no enough information towards this. You can do it, but it's going to be risky because, not risky, but it's going to be difficult because, like I said earlier, suicide is a taboo in our community. So people might deny of having a relative who have died of suicide or things like that. But it would be a very nice research issue if you do it. Can we study suicide prevalence and socio-economic determinant? This is the question I answered. Can you take history from friends and family about a patient you suspect to be suicidal? Without breaching the person's confidentiality, you can do it. You can take collateral history. You can ask, because sometimes people with borderline personality disorder and people with other personality disorders might give out very much exaggerated information, and you can ask the family members, but you shouldn't breach other confidentiality, because you shouldn't tell other history you took from the patient without taking consent from the patient. How do you manage a patient who has suicidal ideation and who has to be admitted but declined admission? The patient declined admission. I'm sure that is the case. There has to be someone around that person, and you have to take away the lethal means that they have. If there is firearm in the house, different types of medications in the house, things like that should be taken away from the patient, and that you have to make sure that if they have seen a physician, that they are taking their medications and that they are going to their follow-up visits, because usually people who have suicidal ideations, like I said, have different types of mental illnesses, and their judgment might be impaired. So there has to be someone who has to, do these things for them. Okay. With schizophrenia, the risk is 12 times increased. So it is high, not as high as major depressive disorder, but it is high. Dagi M posted the question again. So when people are sick and the disease isn't treatable, and if they are suffering a lot, other countries will suggest the idea of taking their life voluntarily. But here in our country, because there is no such option like that, they commit suicide not to suffer from their illness. My question is, why isn't that available here instead of people suffering from their sickness? So you're talking about euthanasia, physician-assisted suicide. Well, it is illegal in our country. And there might be different reasons that the government has made this illegal. And I think one of the reasons might be because we live in a religious country where people have, almost everyone in this country has a religious affiliation. So I think in a religious country, allowing this might be a problem. I think that's why, but I'm not sure. How do we proceed if a patient tells us he or she has planned suicide and homicide to a specific person? You have, this person has to be taken to a physician. This has to be assessed. And if the risk is imminent, if they are going to do it, especially homicide, if they are going to do it, and if it is specific towards one person, the physician should report that to the police, that confidentiality. But you have to be sure. You have to be 100% sure that this person is going to kill that certain somebody that they are said they're going to kill. In that case, you can't keep it confidential, and you have to breach the confidentiality and report it, because it will be your responsibility later on.
Sorry, Doc. Let's take the last one or two questions, and let's conclude.
All right. I think the last two questions are which one is more risk for suicide from medication, antipsychotic or antidepressant? So these medications are actually treatment for suicide, treatment for the underlying cause of people who are suicidal. But what I talked about earlier is people who are taking tricyclic and people we prescribe anticyclic antidepressants too, because tricyclic antidepressants when they are overdosed, their fatality is almost 100%. That's why we refrain from ordering TCA. But if you have to order it, like I said, you have to give it in a small amount to these people, but they don't increase the risk. What about the epidemiology and cause of suicide in Ethiopia? I already talked about the epidemiology, and the causes are not that much different from the worldwide causes of suicide. Mental illness are the common causes of suicide in our country too. But like I said, data is lacking regarding suicide in our country. So I think that's all.
Yeah, that's all. But let me. I think some question caught my eye, and let me give you that question. And it's from anonymous attendee. Can a physician suggest to get religious advice during psychotherapy? That's the final question.
Oh, yes. Religion is one of the protective factors in any type of mental illness, and we support people who are religious. Psychiatry, it's a common misconception. People think that psychiatrists completely deny religiousness, but we actually encourage religiousness and spirituality. Any religion you follow, we actually encourage it because it is a protective factor. It is something that gives people hope. Having God to look after them is that having that idea is a very much protective factor. So we encourage it. So you can take advice from anyone. And
okay. Yeah. Thank you so much, Doctor, for taking your time, especially on the Q&A session. We have taken vast time to answer participants' question, and thank you for that. We hope to see you in another setup and in another topic, maybe in the future, if you're willing and got the time. And thank you so much.
Thank you so much, Adam. Thank you so much, everyone, for participating in this presentation, for raising your questions. I really appreciate it. Have a good night.
All right. Have a good night, Doctor.